Okay. All right. So yeah, so additional testing may be needed. These are the things. Let's do an ultrasound. Okay. All right, guys, who feels comfortable with the GTPAL? We good? So in the chats, open up your chat box. Tell me if your patient is pregnant with twins. Currently, she's 28 weeks gestation. She has a 3-year-old that was born at 38 weeks. She has a 2-year-old that was born at 36 weeks. And she had a spontaneous loss at 9 weeks. What is her GTPAL?
Can you repeat one more time?
Okay. She's currently pregnant with twins. I don't remember how many weeks I said. 28? Sure. 28 weeks pregnant with twins. She has a 38-week kiddo, a 4-year-old that was 38 weeks. She has a 2-year-old that was 36 weeks, and she has a 9-week loss. Okay, she's 28 weeks pregnant with twins. She had one, she has a 4-year-old. That delivered at 38 weeks. She's a 2-year-old delivered at 36 weeks. 9-week delivery. Okay. Morgan's did hers private, but she's the one that's correct. All right, so what's her G?
4.
She's a G4. She's got the twins that she's pregnant with now. She's got the 4-year-old, the 2-year-old, the 9-week loss. She's a G4. What is her T?
One.
Good. She's a T1. What is the term delivery?
38 weeks.
Good. What is so next is P, GTPAL, what's the P?
The 2-year-old.
Okay, and how many P's does she have?
1.
Okay, and that's the 2-year-old that was delivered at 36 weeks. And then A, how many A's does she have?
1.
1. And then how many L?
It was 2.
It's 2. Excuse me. All right, she's got the 4-year-old that's living. She's got the 2-year-old that's living. She has her L as a 2. So now she came into your unit and that was her GTPAL, and now she just delivered. So now what is her GTPAL now? What do you guys think? What's her G? Still a G4. Okay. What's her T?
Still a 1.
Still a 1. What's her P?
Did you say she delivered? You cut out on me. I'm sorry.
Yep.
So a 2.
Okay, she delivered these twins.
So 2.
Is it 2 or 3?
But the 3 is living, but you still would count it as a P also.
Okay, but the
Are
P, she's pregnant with twins. Is the P gonna count as 1 delivery or 2?
Oh, 2.
It's still 2. I mean, it was 1 before. Now it's just 1 more delivery. Okay, she had the 2-year-old that counted as a delivery. The twins count as 1 delivery. Okay. The A is still 1. And what's her L now?
4.
4. She has the 4-year-old, the 2-year-old, and now she just had twins. So this is where we pick those twins up, is in that living category. Under the delivery, under the P, it just counted as 1. Is everybody clear on that? Okay, good.
Can you repeat that, please?
Yep. So she was 28 weeks. She had, I'm going to put in the chat, 28 weeks. She had a 4-year-old at 38 weeks. 2-year-old, 36 weeks. A 9-week loss. Okay. So she was currently 28 weeks. Then she has the 4-year-old, the 2-year-old, and the 9-week delivery. So she delivered those, and the first one was twins. I forgot to put it. So that makes her a G4, T1, P2. Okay, because the 28-week twins counts as 1 delivery, and then the 2-year-old is below 37 weeks. That counts as 1 delivery. A1, L4.
Thank you.
Okay. For gravidity and parity, do you guys remember the terminology that goes with this? If this patient, is she prima gravida or multigravida? Multigravida. Is she a prima para or multipara?
Multi.
Multipara. Yeah, she's had several deliveries, right? So it's more than 1. What if she was G2P1? Would she be multigravida or prima gravida?
Right.
Multi?
For gravidity, she'd be multi. She is a G2, which means she's had 2 pregnancies. So she's a multigravida because it's more than 1. What about her parity? Is she a multipara or a prima para?
Prima.
Prima para. Okay. All right, presumptive, probable, and positive signs of pregnancy. Remember, guys, that for presumptive, we have this S in here in bold to remind you that presumptive is subjective information. So what are examples of presumptive signs of pregnancy?
Missed period.
Missed period, what else?
Nausea.
Yep. Other ideas? Those are the two big ones. They also be like, I've been really tired, my breasts are tender, things like that. Okay. Probable, the O is bolded in probable to remind you that this information is objective. So these are things that you can assess. So what are,
Pregnancy test.
okay, pregnancy test. What else? Oh my gosh, I can't remember the first two. What am I missing? Chadwick sign, Hagar sign, McDonald sign. These are all probable signs of pregnancy. These are things that cause changes to the cervix or the lower uterine segment. Chadwick causes a discoloration. Remember, the color changes to kind of a bluish hue in the vagina and the vulva. Hagar sign, McDonald sign, these are all things that are softening. Okay, so the cervix is softening, the lower uterine segment is softening, things that are softening. But Chadwick's is that discoloration. Those are all probable signs of pregnancy. What about positive? How am I positive she's pregnant?
Ultrasound.
Ultrasound. Okay, I can see the baby on an ultrasound, so I know she's pregnant because I saw it. What about heart rate? If I can hear the baby's heartbeat. So positive signs of pregnancy come from the baby. Okay, specifically from the baby. All right. Then we learned about all these changes that are happening with mom, right? There was all those system changes going on. And one of the big things that that affect a lot of different things, there's two things that really affect a lot in pregnancy. One is hormone changes. All of that progesterone that's maintained the pregnancy is also causing things like discoloration in the skin, like that linea nigra and plasma and stuff like that. And then the increase in the blood volume, okay, is another thing that we are considering because her body increases the volume of blood to nourish this baby because we have a lot of blood going in now that placenta. Okay. Nagel's rule. Do you guys remember how to do Nagel's rule?
Which one? Never.
Nagel's rule to determine a due date.
Oh,
So if her last menstrual period that's her period, February 11th, 2022. Using Nagel's rule, what is her estimated due date? Okay, so those of you that are giving me November 18th, what's the year? It's still 2022. We add a year on if we go into the next year, but by her period being in February, she's going to deliver before the end of the year. So it's still going to be 2022. If this same patient was, let's say April 2022, then what would her due date be? Yep. Good. Okay, so that time we had to change the year. Katrina, did you mean 18 instead of 16? Yep. All right. All right, guys. So nutrition and exercise. So when we're thinking about the kind of things that we are assessing, the things that during pregnancy, the things we're teaching in relation to this. All right, exercise, we are thinking non-weight bearing. We're thinking things like yoga, stretching. Stretching is good to help the body when they're preparing for labor. Swimming, cycling, things that are non-impact. Okay. You guys remember what pica is? Okay, those non-food items. What's that a sign of?
It doesn't depend on like what they're eating.
Yeah.
Like pregnancy deficiency, like sometimes people eat ice if they have an iron deficiency or eat shock. I know.
Okay, iron deficiency. Okay. So if I go to, let's find our high iron foods. What's a high iron food?
Spinach.
Spinach. That's funny. I thought that I could get a good list and instead I got 14 foods high in iron, best iron sources from food. Okay. So spinach is a big one. We know spinach is good for iron. What else? Because if your patient has pica, she probably is iron deficient. Yes, she probably needs iron supplements. We need to remember how to take iron supplements too, but what are some iron-rich foods that's on our list here?
Orange juice. I don't know.
So we got eggs and chicken in the chat. We've got spinach. So things that are like our meats, eggs. Okay. Broccoli is high in iron, lots of different types of beans. Okay, so these are all things that we would want to encourage. Yeah, steak and eggs I have in the chat too. These are all things we would want to encourage our patients to eat if they're iron deficient. Now, what are some teaching items for with iron? Like how to take it.
Take it with juice, citrus.
How to take that?
For
How to take
Okay.
iron?
Okay, so we've got, they can have dark stools, Matthew says. Katrina says no dairy, good. Take it with something acidic, so orange juice, all right? So these are all things to think about. So the things that we don't want them to take it with, dairy, right? Not milk, milk products. Also, guys, think about those that are popping Tums like crazy. Tums are calcium, that's what it does. So don't take it with your Tums. All right. The other thing that is interesting to affect the absorption of iron is going to be coffee and tea. So don't take it with your orange juice, but don't take it with your milk, coffee, or tea. Okay. Yeah, so then I've got empty stomach 1 to 2 hours after a meal. Yep, so all these things are going to help with absorption. Okay. What's the normal weight gain for pregnancy? Anybody remember? Katrina says 30 pounds. What do you think? You think she's right? So we're going to do Matthew says 20 to 30. It's usually 25 to 35 if she is starting out with a normal BMI. Those first 12 weeks, they only gain like 4 to 6 pounds. And then it's a half a pound to a pound a week, roughly. So it ends up being about 25 to 35 pounds. If they're gaining a lot of weight in a short period of time, what might I be worried about?
Hypertension.
Tell me again.
Low sugar, blood, or hypertension.
Gestational diabetes.
Okay. Okay,
Mhm.
we could be concerned about diabetes. One thing that I'm more concerned about is going to be a condition that causes a rapid onset of edema and weight gain. What do you think?
Preeclampsia.
Preeclampsia.
Yep, preeclampsia. If she starts gaining a ton of weight really quickly, I'm worried about preeclampsia. Why is she retaining so much fluid? Okay. What are some things that we're thinking about nutrition wise for our adolescents in pregnancy? What do you think? Adolescents.
Making sure they're gaining enough weight because they can have like self-image issues.
Good. Yep. Yep.
Making sure that they're eating the right kind of foods instead of like fast foods and things like that.
Yep. Good. All right. They have body image issues. They might not be eating healthy. Okay. So we did, I think one of your exams had a question about that as far as having a dietitian or nutrition consult for that reason. They have higher incidence of having growth restricted babies, higher incidence of iron deficiency, anemia, things like that. So we need to just really be very aware of that. Okay. All right, our prenatal visits. What lab work do we want to know at the beginning?
Urine analysis, check for protein.
Okay.
Is it H? I don't know what the hormone is. HC.
Oh, HCG.
Yeah.
Okay. The HCG is what we test for pregnancy. Okay,
RH,
good. Why
Okay.
do I care about the RH?
because you don't want a negative mom with a positive baby, because they're gonna have to get a RhoGAM shot if so.
Okay, so we want to know that in advance. What else?
The mom's blood type.
Okay. Yep, mom's blood type, and that kind of goes with the RH factor. And if
And-
mom's negative,
Any we would want to know if she had STIs.
okay. Yep, we would want to know if she has STIs. We'll test for that, especially chlamydia and gonorrhea. Why do I care about chlamydia and gonorrhea?
Because it can cause infection to the baby's eyes.
Okay. And what about HIV? I would want to know that one. Why do I care about that? If she's HIV positive, is there anything I'm going to do different during her pregnancy to help reduce the risk of transmission to the baby?
Not during. Isn't it after?
We're going to do this through the whole pregnancy. I'm looking up the way to spell it. I'm going to put it in your chat.
Is it the immunoglobulin or replacement?
Not quite.
Okay.
So yeah, we wouldn't be doing that right now. But this one, Zuvadine, this is the antiretroviral that we give to moms during pregnancy. And its job is to help minimize the risk of transmission to the baby. Okay, so it minimizes the risk of transmission to the baby. It doesn't cure HIV, but it tries to minimize that risk. We also give it to babies after they're born. We give it to moms in labor. We just really, it does a really good job of decreasing transmission. Okay, so I want to know if she has HIV. What about rubella? Some of these guys come up when we talk about torch infections. So I want to know if she's rubella immune or non-immune. And if you remember, when we talk about torch infections, rubella is something that can be detrimental to the pregnancy. So if she's non-immune, can I vaccinate her now?
No,
No. Why?
because the vaccine
It's live.
Good. The vaccine's live. Okay. All right. So we're going to do all this lab work. We're going to find out. Also, I want to know we'll look at her hematocrit and hemoglobin and see. And so we're doing the CBC. We're looking to see if she's anemic. We're looking to, we're testing for all these things to start. Now we are going to do a fetal assessment. For fetal assessment, we'll listen to the heart tones, but one of the things we're teaching moms about is kick counts. Do you guys know or remember what kick counts are?
Is that the baby movement, right? How many times you feel the baby moving within is it an hour?
Yep.
Feel like 10 times, I think.
Yep. We want 10 movements in an hour. And we say an hour or two. And the reason why is because sometimes babies take a nap and they're sleeping and they're not really moving for part of that hour. And so if they don't get 10 movements in the first hour, they can count into the second hour. Okay. Preferably we get 10 movements in the first hour. And once they start feeling the baby's movements, we want them to be assessing this every day. And this is something when we think about our high-risk babies, our high-risk moms, the kick counts is something that we rely on for fetal well-being. How's your baby moving? Are you doing kick counts every day? Our physical exam at each appointment, we're checking the weight, which we already talked about. We're checking for protein in the urine, which we already talked about. They have higher prevalence of UTIs. And somebody mentioned UTIs already. Because especially in that last trimester, the bladder isn't emptying well. Okay. If they get a UTI in the last trimester, though, that increases their risk of having contractions, preterm labor. They can develop, oh my gosh, pyelonephritis, where that infection travels up into the kidneys, and that can be really bad because they can actually develop a systemic infection from that. So, so for a lot of women, they might not be prone to UTIs usually, but in pregnancy, they could be more so. Some of them are on prophylactic medications and different things like that. We're also assessing the blood pressure at each visit.
I'm sorry, Professor. So the UTI is advised to do it in the last trimester.
The UTIs in the last trimester, the bigger concern is the preterm labor and, and increased risk of having a bigger infection like pyelonephritis.
Okay, thank you.
Okay. Blood pressures, we're doing them at each appointment. What are we checking for?
A high blood pressure?
We're looking to make sure that it's not high. Because if it's high, what am I worried about?
Preeclampsia.
Good. We'll measure fundal height. And when we measure the fundal height, that's when we do the tape measure from the pubis up to the top of the fundus. And that gives us a pretty good indication of the baby's growth. And we expect that number in centimeters to be plus or minus 2 from the gestational weeks. So if I measure 38 and she's 38 weeks pregnant, I'm right on track. If I measure 34 and she's 38 weeks pregnant, then maybe I'm concerned because that's more than the plus or minus 2. We're assessing for intimate partner violence, and we spent a lot of time talking about that in class this term. We're educating about our pregnancy discomforts. All right, big ones are going to be the back pain. Okay, back pain, like from lordosis, is normal. And back pain, and then also the lower abdominal pains can be normal unless they come and go. If they come and go, what am I worried about? What could be causing pain in the back that comes and goes? Rebecca's got it. How about contractions? Okay, so if the back pain is constant, then that's probably normal. If it comes and goes, then I want to assess further and make sure she's not contracting. Okay, heartburn is a very normal finding in pregnancy. We learned a lot about different things they can do with diet and the way they eat to help minimize heartburn. Same with constipation. Okay. And then a lot of the other things we're doing with our prenatal visits have to do with education. All right, teaching about breastfeeding, teaching about Kegel exercises, exercises in general, which was on this slide here. All right, so kick counts we just talked about. You guys have it. Okay. Ultrasound is another thing that we can do to determine fetal well-being. We already talked about using that potentially if we have like a low alpha fetoprotein and we're concerned about Down syndrome. There's a lot of other things that ultrasound does for us. We can do a review of systems and look at the baby overall, all the organ systems and how things are doing. We can assess. So if guys, let's say I did a fundal height and I said, if she was 38 weeks and she measured 34, I might be worried. The very next thing I would come to is an ultrasound. Let's look at how that baby's growing. Okay, we can get a really good assessment of the baby size and how the baby's growing with an ultrasound. Okay. What is a non-stress test? You guys remember non-stress test?
It's a test that they do for high-risk pregnancies.
Okay. Yep, we do it for high-risk pregnancies, and we do it sometimes every week. Okay, what is it though?
Monitoring the baby's heart rate, respond to the mood.
And fetal oxygenation. It
Okay, good.
evaluates.
All right, so we're putting the monitors on and we're watching the tracing. And we can look at the baby's heart rate. We can look for the things that are reassuring that the baby is well oxygenated. Okay, so on a non-stress test, how long are we evaluating for?
Is it an hour?
15 minutes by 15 seconds.
That's the 15 by 15 is for some, it's part of this, but it's for something else. Our non-stress test is 20 minutes.
20 minutes.
Okay. And in that 20 minutes of time, what do I want to see to be reassured that my baby is well oxygenated and doing well?
Variability.
Variability. What kind of variability?
Moderate.
Variability. There we go. I can't type. All right, moderate variability. What else?
Accelerations.
I was about to say that.
Okay, accelerations. How many?
Oh, now you got me there.
15 by 15.
They need to be at least 15 by 15. So, okay, first of all, for our accelerations on a non-stress test, we need at least 2 in that 20 minutes.
Okay.
And then they do need to be at least 15 seconds long and at least 15 beats above the baseline.
Mm.
So that's where that 15 by 15 comes in, is that it goes up at least 15 beats above the baseline and it lasts for at least 15 seconds. So if your baby, now truly, if your patient's less than 32 weeks, then it can be 10 by 10. Then it can be 10 by 10. But let's say your patient's 36 weeks and you see 2 accelerations, but they are 10 by 10. Reassuring or non-reassuring? It's not it's not going to count as an acceleration unless it hits that 15 by 15 parameter.
Oh, okay.
So we're talking about the baseline being 15 beats above the baseline. So what kind of baseline do we want?
Yes. 100. You also.
Like for the heart rate?
Yep.
Oh, 110 to 160?
110 to 160. Okay. All right, so those are our non-stress test things. We want baseline in the normal range. We want moderate variability. We want at least 2 accelerations that meet criteria of at least 15 seconds long and at least 15 beats above the baseline. All right, you can have more than 2 accelerations. They can last longer than 15. It can be more. We just don't want it to be less. Okay. Now that's your non-stress test. With a contraction stress test, difference here is the criteria that we're looking for is the same. But what we're doing is instead of just putting the monitor on and just seeing how the baby's doing just in normal life, we actually can give mom Pitocin and cause her uterus to contract. And when she has a contraction, we look at this baby and see how's the baby responding to the contractions, because we would like to have no decelerations. Even the ones that we consider normal for labor. What's a deceleration that I'm not worried about in labor?
Okay.
What do you think?
Early deceleration.
Early decelerations are normal in labor. They're not normal for a contraction stress test. Okay, because what causes an early deceleration?
Can you repeat again the acceleration? That's not normal.
Okay, and I'm trying to also put in the chat. I know we're getting some background noise too. I apologize.
Yes.
The early decelerations are normal in labor. They're not normal for our non-stress tests or our contraction stress tests, because what causes an early deceleration? Do you remember?
Is it 1,000? Okay,
So
later.
anybody who's not talking, can you please mute?
That's cord compression, or no, early. That's head compression.
Yeah. So early decelerations are caused by head compression. And so should I see head compression when she's not in labor? No. So non-stress tests and contraction stress tests should not have any decelerations in it. Okay.
Okay.
Okay. So substance abuse. When we think about and STDs or STIs, when we think about smoking, what are we concerned about? What's the concern with smoking?
Low birth weight?
Mm-hmm. Low birth weight. Why? Why do you think that babies that are born to moms who smoke have lower birth weight?
Perfusion, oxygen perfusion.
Yep.
Or placental perfusion.
Yep. Okay, because we have chronic vasoconstriction with smoking. And we're getting chronic decrease in perfusion to the placenta. All right. So for an example, I used to be a smoker. I smoked for my first 3 pregnancies, and I did not smoke for my last 2. I have 5 kids. My first 3 babies all weighed high 6s, 6 pounds, 11 ounces, 6 pounds, 7 ounces. My last 2 babies weighed over 8 pounds. Okay. And all things being equal, my diet and things were the same. So it decreases their birth weight. Okay. And then for our illicit drugs, there's so many things that we learned about that went with drugs, right? We talked about it in relation to the mom, and we talked about it in relation to the baby. And I do think we'll look at neonatal absence syndrome. Well, no, it's right here. I was going to say in a minute, but it's here. So for mom, what are we thinking about when it comes to drug use? You guys, excuse me, do you remember that things
Everything
like
crosses the placenta.
everything crosses the placenta, and things like cocaine can cause placental abruption. Okay. And methadone is an acceptable option to get off of the opioids. Yeah, so Josh says high risk for precipitous labor. Okay, because the cocaine can cause placental abruption and precipitous labor. Absolutely. So now what do we think about for the baby? The baby that's born to the drug addicted mom. Now this baby is going to go through withdrawal. So we learned about neonatal absence syndrome. And the signs and symptoms there's so many. When this baby's withdrawing, they have so many things. One of the things, okay, so Katrina says moms can't breastfeed. They can maybe. There's a couple of things about breastfeeding. We want to keep in mind that if they're still on those drugs, that it's going to cross through the breast milk. If she's taking methadone, that is safe for breastfeeding. And if mom is not still currently using the drugs, they often will still go ahead and have her breastfeed, even if there's a little bit of it still in her system, because the amount that's crossing through to the breast milk is minimal, and it can help babies with their withdrawal symptoms. So it depends. If she's still using, she shouldn't, because everything crosses into breast milk, same as everything crosses through the placenta. Signs and symptoms of neonatal absence syndrome: high-pitched shrill cry, tremors, seizures, frequent yawning, frequent sneezing, poor feeding. And these are the babies that we really want to swaddle, and we want to keep them in calm and quiet environments. And so like the eat sleep console model that if you're in my class, I posted in your discussion board, a lot of the hospitals are going toward that model. Babies still need to be oftentimes on morphine for their symptoms, and sometimes on phenobarbital to try to minimize their seizure risk. But a lot of it is going to be keeping them in that calm environment and helping them transition through that. So we already talked about HIV. Okay. And so HIV, and I put in the chat, Zuvudine is the medicine that we're giving to moms and we're giving to babies. Herpes. What do you think about herpes? If mom has lesions, can she have a vaginal birth?
No.
No. If she has lesions and she has a precipitous delivery and delivers anyway, then we need to isolate that baby from other babies. Okay, because it's very contagious and we don't want to spread the possibility that the baby contracted it is high and we don't want it to spread to other babies. If she doesn't have lesions, but she has a history of herpes, can she deliver vaginally?
Yes.
Good. Does anybody know what we use to try to minimize her risk of outbreak so she can have a vaginal delivery? Yep, Katrina says antiviral. So acyclovir. Congenital anomalies. We discussed spina bifida and anencephaly. What is the we discussed it in relation to our alpha fetoprotein. If the alpha fetoprotein is what do I think maybe spina bifida and neurotube defects? What was the alpha fetoprotein level, high or low? Josh says high.
Low.
He's right.
Oh, hi.
Okay, remember that for alpha fetoprotein, if it's high, I'm thinking neural tube defects. If it's low, I'm thinking Down syndrome. So you can think low down. Okay, what's something that we have moms do to help minimize the risk of having babies with neural tube defects?
Folic acid.
Folic acid. When's the best time for them to take folic acid in order for it to be effective to minimize neural tube defects for their babies?
When they're trying to still get pregnant.
Yep, before they get pregnant. Before conception is the best time. Okay. A lot of our congenital anomalies we can test for with that amniocentesis. And some of them are going to be like the severity, or I mean, the treatment is going to depend on the severity. So like some like heart defects and abdominal wall defects and things like that have to be surgical interventions immediately. If they have a spina bifida, so they have neural tube defect, which causes a myelomeningocele, that's going to need to be treated right away. Some of these though are things that they can be treated with rehab, like hip dysplasia. How would I know if my baby has hip dysplasia? What are some signs of hip dysplasia? Anybody know? Unequal gluteal folds when you look at them on their backside. All right, torch complex. So we talked about a lot of this. We talked about HIV. We talked about the need for the antiretroviral AZT, which is Zuvudine. We've talked about herpes. Our signs and symptoms of herpes in relation to those lesions are going to be itching, blisters, maybe pain. Okay. The other part of torch infection is toxoplasmosis. All right, toxoplasmosis is a parasite found in cat feces. It's also found in raw meat. It also can be found on unwashed fruits and vegetables. And so women who are pregnant shouldn't change the cat's litter box. All right, because the risk of toxoplasmosis. Okay, signs of labor. You guys remember the P's, right? What are our P's for labor? What do you think? You can put in the chat. I'm going to take the easy ones. Passengers 1. What else? Passenger. Our passengers are baby or the placenta. Our passageway. There we go. Katrina's got power. Passageway is our vagina. It's the going through the pelvis. Okay. So we got power is another P. Placenta is one of our passengers. Okay. We have passageway, passenger, power, position. And then there's one other one. There you go. Psychology. How's mom coping? All right. How do I know it's true labor versus false labor? Okay, contraction
labor.
time and strength, maybe. Go ahead, Jasmine, what are you gonna say?
I was gonna say contractions with cervical change.
Cervical change is the key. Okay, we can look at the time and strength of the contractions, but if they're not changing the cervix, then it's not going to be labor. The thing that we really see is that walking increases. All right, so with true labor, if they're walking and they're active, the contractions get stronger and closer together. With false labor, oftentimes with walking and activity, the contractions space out. And so that's often a sign that her contractions are Braxton Hicks contractions, or pre-labor contractions, or false labor contractions, however you want to look at it. Okay. So signs of early labor are going to be contractions. They could be increasing in intensity and frequency, cervical change. She might have some bloody show. She might lose her mucus plug. Increase in pelvic pressure, things like that. For rupture of membranes, if the water breaks, what do I want to know? What do I want to know when the water breaks? I want to know what time it broke, because I'm going to keep track of how long. I want to know if it has an odor. I want to know how much. There's something else I want to know. What do you think? Nikki's got it. Let's find out what color it is. Because guys, if it is not clear, then I'm concerned that either, depending on what color it is, I'm concerned that we could have meconium stained fluid. What color would it be with meconium stained fluid? What do you think? Greenish. Nikki is funny because I'm typing the word and then I send and then I look and she sent the exact same thing. Nikki and I were on the same wavelength. Okay, greenish colored. See, we did it with color and we did it with greenish. Good. All right, so if it's a greenish color, then we're worried about meconium stained fluid. And I really want to assess the fetal heart rate. Okay, because meconium stained fluid can be an indication that we've had some fetal distress. And we might even see a heart rate going down after the water breaks as well. Okay. What else? If it's yellowish, maybe I'm worried about infection. If it's got blood in it, I could be worried about an abruption. There's a lot of different things why I want to look and see what color it is. Okay, most often though, the thing we see that we're concerned about is meconium stained fluid. And then guys, you remember the stages of labor. What's the first stage? First stage of labor.
Transition vaginal exam prior intubation.
Okay, so first stage is onset to 10 centimeters. That includes transition. And what is transition? What is it? Okay, Josh has 8 to 10. So guys, the transition phase. So we have the phases, right? So in the first stage, we have onset to 10 centimeters. We have the first phase, which is up to 6 centimeters. Second phase is active. So the first one up to 6 centimeters is latent, sorry. First phase is latent. Second phase is active labor, and then the other phase is transition phase. And like Josh says, it's about 8 centimeters is when we see it. And so it is what defines it isn't the cervical dilation, it's defined by pressure, the urge to bear down. So this part is where she is feeling a lot of pressure. She might want to push. Excuse me. The last little bit of cervix still needs to go away. It needs to finish dilating. If she pushes on this cervix that's still there, it can tear, it can bleed, it's bad. So we need to help her maintain control, good controlled breathing, and have her not push until she's completely dilated. So that's transition. Okay, so we're supporting her if she's unmedicated, and sometimes even with an epidural, that pressure can still be really strong, and we're supporting that mom and keeping her from bearing down on that cervix during transition. Okay, how do I know when she's dilated to? How do I do a vag exam?
With your fingers?
With my fingers. So we're going to use a sterile glove and gel, 2 fingers, palm up, and then we gently put our fingers in the vagina and we measure how we find the cervix, and then we see how far we can open our fingers within the cervix to determine how many centimeters dilated she is. For client prioritization, any of these questions that are for priorities, whether it's in labor, whether it's during birth, whether it's babies, whatever it is, you're going to just need to go with what you know. And if you know that you have, let's say, a prima, let's say a prima gravida. So she hasn't had a baby before. If you have a prima gravida that is contracting every 5 minutes and is 2 centimeters dilated, and you have a multigravida, multipara, who's 8 centimeters without an epidural and starting to grunt and bear down, and you think she's in transition, then it's pretty easy to decide what your priority is there. Which patient would you see first? You see the one that's grunting and bearing down, right? So prioritization is going to be just taking what it tells you and deciding which one is the priority. What is second stage? Okay, full cervical dilation to deliver the baby. Okay, so then the baby's delivered, that's second stage. What's third stage?
Delivery of the placenta.
Okay, delivery of the placenta, and then what's fourth stage? Okay, so Josh has 1 to 4 hours after delivery. Our fourth stage is usually the first 2 hours. after the baby's born. And so in 4th stage, we are monitoring both mom and baby. We're checking to make sure the fundus is firm and that her bleeding is normal. And also baby's vital signs are good. We don't see signs of respiratory distress. We're getting the baby breastfeeding. There's a lot that's going on in those first 2 hours. And so considerations if she delivers outside of the hospital. Let's say she delivered on an airplane or, you know, in her basement or in the grocery store, or what are some considerations if you were there? Let's say the airplane, you were there, she just had a baby. What are some things that you could do that would be important for her? Any ideas?
Important for the mom or the baby?
Both.
Oh, we can definitely make sure the baby is looking okay, is breathing fine.
Okay.
Vital sign. Call the, I don't know. Vital sign.
Well, on an airplane, it might be hard to do vital signs. We can like put our hand on the baby's chest and feel the heartbeat, but we couldn't like take mom's blood pressure.
Mhm.
Maybe you can. All right, I got keep baby dry and warm. How would I do that?
Oh, use a towel to dry the baby off and then wrap them in a dry towel.
Let's put the baby skin to skin.
Oh,
Yeah, it's a good idea to dry the baby, but then let's put the baby skin to skin. Skin to skin is going to help with thermal regulation for the baby. Okay. And we can definitely for our baby assess for signs of respiratory distress. Right? What kind of signs might we see with respiratory distress?
grunting, nasal flaring.
Mm-hmm. What else? Grunting, nasal flaring, retractions, cyanosis, respiratory rate greater than 60, heart rate less than 110. Okay. What about for mom? The biggest thing I'm worried about for mom right after delivery is bleeding.
Bleeding, yeah.
So what could we do that would benefit both mom and baby?
Massage the fundus.
Okay, we could massage the fundus, but
Breastfeed.
let's get that baby on the breast. Because guys, if we latch the baby, mom's body releases what?
Oxytocin.
Yep. Okay, so let's get the baby skin to skin and breastfeeding. All right. Now, the idea of massaging the fundus, we can, but I don't know. It depends on if the placenta's out yet. If that's really going to do us any good. Once the placenta's out, absolutely, we need to massage the fundus. Okay. But it's not going to do us a lot of good until the placenta delivers. But oxytocin is going to help. And oxytocin will be released with breastfeeding. Good job. All right, a lot of this stuff with fetal monitoring, we already talked about it. We talked about early signs of labor, pain control. We talked about pain control in relation to transition and the really helping them focus on their breathing. There's a lot that comes with breathing and non-pharmacologic pain management. Okay. So what are some non-pharmacologic pain management options in labor? Breathing is one. What else? How about water therapy, shower, tub, touch, like effleurage
Listening
or
to music.
good music. Okay. Position changes. Early in labor, walking is great. Early in labor, getting her walking is probably the best thing that you can do for her. We don't want her to get an epidural too soon. There's some thought on this in practice that they can get an epidural anytime. But in NCLEX world, we do not want them to get an epidural too soon because that is the concern is it can slow the labor down. Okay, so early in labor, it is
Matthew.
better to get them walking, get them moving, use some of our non-pharmacologic techniques until their contractions are worsening. And then once they get an epidural, what are my considerations for epidural anesthesia? What do you think?
Consideration.
So if my patient wants an epidural, what is the first thing that I'm going to do you think?
Blood pressure.
Okay, let's start. Let's know what her baseline blood pressure is and what else.
Make sure her bladder is empty.
Okay, we can empty her bladder. I want to give her a fluid bolus. Why would I want to give her fluid bolus before her epidural? Any idea?
So that she doesn't go into shock.
Okay, from what? Like, what are you thinking about with that?
I'm thinking like the blood, like with the epidural, the blood pressure could drop.
There you go.
And then she can potentially go into shock.
Okay. Well, I thought that's where you were at. I was just making sure. Okay, so that's the thing is that, guys, when they get an epidural, the medicine from the epidural causes vasodilation. It causes the vasculature to relax. And so if we give her a fluid bolus, then that's going to help support that blood pressure because as the vasculature relaxes, the blood pressure can go down. So if we give her fluid bolus, it's going to help support that blood pressure, right? And Nikki has it too. So blood pressure doesn't drop too low. So we're going to give her fluid bolus. And we're gonna be assessing her blood pressures throughout. Okay. After the epidural is placed, I'm watching that blood pressure. That is the number one thing, guys, is hypotension from the epidural. Okay. Because that affects the way we perfuse our placenta. That affects the oxygenation for the baby. All right. Also, the other things we learned about has to do with the fact that she doesn't have good sensation now from her belly button down. So we have to manage her bladder. We need to assess her pain. We need to, she's a fall risk now. Okay, she can't get up and walk around. There's some epidurals that are designed to still allow her to stand up. I don't have experience with those. For the most part, for what you guys need to know, she's a fall risk. Okay. Now, so when we think about epidural timing, we said, let's not get it too soon. When we think about the blood pressure, we just talked about how to support the blood pressure. What about a post-epidural headache? So here's what I'm going to tell you guys about post-epidural headache. Okay. So a placement of an epidural should not cause a headache. It shouldn't, because the epidural space does not go where the cerebral spinal fluid is. All right. The cerebral spinal fluid is past the epidural space, past the dura, then you've got cerebral spinal fluid. And what causes a headache is if that cerebral spinal fluid leaks. The reason that we could get a post-epidural headache is if when they're putting that needle in to place the epidural tube, if the needle accidentally nicks the dura and causes a cerebral spinal fluid leak. I'm not going to see that headache until tomorrow. All right. This is not something that's happening today with her epidural. This is something we could see later because it would be a tiny leak. And the little tube from the epidural is going to kind of tamponade that until after it comes out. And then the leaking from the cerebrospinal fluid would be what causes a post-epidural headache. That's something I'd see tomorrow on mom baby. Okay. And the thing with a post-epidural headache is it's positional. So if she's laying down, everything is balanced. When she sits up, we have less cerebrospinal fluid if it's leaking, and now it kind of causes less in her head when she sits up, and that's what causes that headache. Okay, and they can treat this with something called a blood patch. Okay, the blood patch, what we do is we take blood from mom, and then the anesthesiologist is back behind the patient and cleans her back off and does everything the same as when they place the epidural. And then we take blood from mom and sterilely give it to the anesthesiologist, and they inject that blood into the epidural space, and it makes a placeholder until that little spot can heal. So, so that's how we fix a post-epidural headache. It's with a blood patch. All right, we talked about fetal assessment. What affects fetal oxygenation? What do you think? What affects fetal oxygenation?
The placental perfusion.
Placental perfusion, 100%. Okay, if we're not perfusing the placenta, we're affecting the baby's oxygenation. Okay, so I'm grabbing a document here. Okay, so blood pressure is one of those things. When we're talking about the epidural, we're thinking about if her blood pressure gets too low, that's going to affect the baby's oxygenation. It affects the perfusion. All right, fetal monitoring. Guys, veal chop is your friend. This thing here. If you don't know it, I would memorize it. And I'm going to take it a step further, and I'm going to change my share and show you this. This is veal chop plus. So veal chop still. And then we use mine to remind us what to do. Okay. So on our slides, it says decelerations, what's the cause and what's the action? This is your cause, this is your action. So here's what I'm going to tell you about what you could potentially see on your HESI or on NCLEX. It's not going to show you a tracing and say what's happening here, but it might say things like the nurse notices a decrease in the baseline that mirrors the contraction. If it said mirrors the contraction, what does that mean? Do you think? What kind of deceleration is that?
What'd you say? I'm sorry.
If you say, for example, if your test said the nurse notices a decrease from the baseline that mirrors the contraction, what kind of deceleration do you think that is if it mirrors the contraction?
The early deceleration.
It'd be an early deceleration. Okay. An early deceleration mirrors the contraction. It starts when the contraction starts, and it ends when the contraction ends. So I can show you example here. I'm going to go to this slide. So here we have the onset is at the beginning of the contraction. The nadir is the bottom, and it's at the peak of the contraction, and then it resolves to the baseline at the same time the contraction ends. They mirror each other. That is an early deceleration. So now if you think about veal chop, the E is for early. Veal chop says that's caused by head compression. So am I worried about that? Is that a concerning finding? No. So we don't need to do anything. So under veal chop mine reminds us that I is interventions not needed. If it says the nurse observes a decrease from the baseline that mirrors the contraction, what is the priority action? There's nothing to do. So anything that would say document the finding or whatever, okay, say, yep, that's fine, right? Now let's say it says, so with, where's my chat box? So with early decelerations, we're talking.
Miss McBride,
Yep,
can we have this veal chop
Yep.
shebang? I got the other one, but I don't have this one with the extra stuff at the bottom.
all right.
Did you put that in the chat?
No, I'll put it in right now.
Thank you.
I'll put it in the chat. Here it comes. It should be coming in the chat. So with an early, it's gonna, the words would be things like mirror or at the same time. Those words tell you that it's an early deceleration. Okay. All right. Now what kind of words might you see for a variable? What words might describe a variable deceleration? What do you think?
Something about the heart rate dropping, maybe?
Yeah, but what kind of words might we see? Like exactly, describe a variable to me. What I would anticipate is things like abrupt.
Okay.
Okay, so let's look at it. So let me go back to the PowerPoint. And then this kind of deceleration here. Abrupt, so here, abrupt onset to naders less than 30 seconds. The variable deceleration also, this is the only deceleration that also meets 15 by 15 criteria. All right, so it is gonna go down below the baseline at least 15 beats and last for at least 15 seconds. So it's similar in our accelerations, except for instead of going up, it's going down. And so we see an abrupt onset. What causes a variable deceleration?
Cord compression.
Yep. Caused by cord compression. Now, this does not matter how it times with the contraction. Do you see at the bottom of this, it says the relationship to the contraction is variable. It's possible that the contraction is what's causing compression of the cord, but it's also possible it isn't. We did a C-section on a baby that was just holding onto his cord and he just kept squeezing it. We didn't know that that was why we were having big variables, but it was because he was squeezing his own cord. So if we have variable decelerations, those are called, veal chop says that's cord compression. Veal chop mine says, let's move mom. Because if the cord is somewhere between baby and mom, changing mom's position is going to get pressure off the cord.
So sorry, it's not specific to moving her to the left side for cord
Well,
compression?
we tell you left side, left side, left side. Okay,
Uh-huh.
because the left side is going to perfuse the placenta better.
Mm-hmm.
But truly, just, what if you go in there and you
And
see
she's
this,
on
and
her
she's
left
already
side.
on her left side?
Right, that's why
Let's
I
go
asked.
right. Yep,
Okay.
it's not, so yes, left side, but not exclusively left side.
Okay.
All right, left side is good, but just move her. If I'm watching my tracing and I see a big variable, I just walk in and I go, okay, she's on her left, let's go right. Sometimes we go left and then we could look at the monitor and it's not better. So we go right and we look at the monitor. That's not better either. So let's sit up. Let's go hands and knees, whatever. We just move mom. Okay.
So I'm sorry, I just got a question.
Yeah.
So in the event that that happens and she needs to be moved, but she has a epidural,
Yeah.
so what will we do?
If she needs to be moved and she has an epidural, we are going to still move her. We just
Okay.
are going to maybe need help. It depends on how dense her epidural is. A lot of times women can still use their bodies pretty well with an epidural. But usually here's what happens is that on labor and delivery, we all play together. We see all the strips. And if the heart tones are going down, all the nurses go. And so you have lots of hands and you have, so this one here, if you look on VealChat mine at this bottom one, and it says stop Pitocin, position change, oxygen, IV fluid, all of that. You've got one nurse doing the fluid. You've got one nurse, you know, grabbing, if we need a tocolytic, they went to go get it. If we need, one is, and then we have more than one helping turn the patient. And then we'll turn her and then move the monitor and listen to the baby. Did it help? Nope. Let's go the other way. And then you've got two nurses helping turn her the other way. And then we listen. Did it help? Nope. That's not better either. I have put a woman with epidural on hands and knees. It's not always easy, but if that's the only thing that's going to fix baby, sometimes it takes 3 nurses to do it. So yeah, even with an epidural, things are a little more difficult, more challenging, but can still happen. All right, so that's our variables. Variables, cord compression, move mom. Okay. Now, now we talked about accelerations, right? Accelerations are good. So in VealChat mine, we have nothing to do. Accelerations are good. Late decelerations are our most concerning. All right, lates are most concerning. What causes a late deceleration?
Placental inefficiency.
Yeah, so we have poor placental perfusion. What does it look like?
So whenever baby's breathings are shallow.
Well, but baby's still in utero. So what would I see on our monitor?
That's what I wanted to say, but I could not figure it out the right words.
Okay, you got it. All right, so the onset, so Katrina says after the contraction, onset happens usually during the contraction, usually during the peak actually. Contraction does not recover to baseline
Yes.
until after contraction ends. Okay, so it looks like now let's see, it looks like this one. So see, this started while the contraction was still happening.
Right.
And it did not get back to the baseline until well after the contraction was over. These are the ones I'm the most worried about, and these are the ones that have the most interventions. The first interventions is going to still be move mom, because if I move the mom, this position change here, if I move the mom, that might improve the perfusion to the placenta. What if she was supine hypotension? She was laying on her back. Okay, so move mom is still the thing I can do first. But now I'm considering, why am I not perfusing this placenta well? It can be we just gave her an epidural and her blood pressure is 80/40. And so IV fluid is a good choice. to help improve the blood pressure. It could be she's having too many contractions. So guys, remember that every time the uterus contracts, I'm getting less blood flow through the muscle to the placenta. So if we're having contractions that are too strong and too close together, now I'm not perfusing the baby as well because I'm not perfusing the placenta. So we can turn off Pitocin. We can also give a tocolytic here. What's the tocolytic we would use? We're thinking about terbutaline for this.
Tachycardia.
But terbutaline causes tachycardia, so I want to do vital signs before I give it. But for my late decelerations, I'm turning off the Pitocin, I'm moving mom's position, I can give oxygen, I can give IV fluid, I can treat her blood pressure, and I can give tocolytics. All right. So these are the ones that if you see it in words, it says onset after the start of the contraction, or it does not resolve to baseline until after the contraction ends. It has the word after. So I'm actually going to say after. And here I'm going to say mirrors. And here I'm going to say abrupt. And those are going to be our keywords. I'm going to say mirrors or at the same time. Okay, so I'll put it in the chat again with the keywords in it.
So those are keywords with a question on the HESI.
Those are going to be the type of things you would see in your test question. These words. If it says abrupt onset, that is an indication that it's a variable. If it says it mirrors or it happens at the same time, that's an indication that it's an early. And if it says the word after, that's an indication that it's late.
Okay, thank you, Professor.
Okay. Does that make sense to everybody? I do think that you guys have fetal monitoring questions. So if you can remember this, I think you'll be good. All right, let me go back to our PowerPoint. Okay. All right, so there's your, so if I go back to where we were at here, deceleration causes and actions, that's what we just talked about. Meconium staining, we already talked about when the water breaks and if the water's green, and we talked about signs of respiratory distress in our newborn. This is our variability. This is another picture of it. So when we talk about variability with our fetal heart tracing, that is our squiggly line. And so when we talked about our non-stress tests, and Morgan told us that we wanted moderate, oops, I didn't mean to move it. We wanted moderate variability. And that's when that variation is between 5 and 25 beats from around the baseline. Between 5 and 25. Okay, so moderate is what we want. Okay, the other ones are examples of the other things we could see, but moderate's what we want. And then we just discussed accelerations and decelerations in great detail. And we also discussed this. So guys, when on the VealChat Mind page that I had pulled up, it had this acronym under LATES. It's the same thing. All right. Another thing, if it's easier for you to remember, you can remember the Lion mnemonic, and that is left side, IV fluid, oxygen, and notify, which is easy, but like we already said, sometimes left side isn't the side, right? Also, sometimes we need to turn off our Pitocin, or we need to treat our blood pressure, or we need to do tocolytics and things like that. And so that's why this one's better, to really consider all of the things that might need to be done. And that's what was in the VealChat Mind document that I put in the chat. Okay. For contractions, the way that we time contractions, let me zoom this in. This example counts peak to peak for frequency. I learned to count beginning to beginning. It's going to be the same thing. All right. We're going to go from one contraction to the next contraction. That's your frequency. Your duration is how long it's lasting. It shouldn't last more than 90 seconds because remember, every time the uterus is contracted, we have less blood flow going to baby, we have less oxygen. So if it's contracted for longer than 90 seconds, then we're getting less oxygenation to our kiddo. All right. Considerations for cesarean. So what are some things that we are thinking about if a patient's going to have a C-section? What do you think?
Like sometime umbilical cord got around baby.
Okay, so you're thinking about like a reason why we would need to do one. That would be a reason, yeah. Let's think about what we're going to consider if we're doing it. So let's think about medications. What medicines might we give a patient that's going to have a cesarean? We're going to give them an antacid, usually Pepsid, because if they're laying on their back and they vomit, I don't want a lot of really acidic stomach. Yep.
Okay.
So let's give her an antacid. Let's give her an antibiotic because the antibiotic is going to help minimize our risk of endometritis because we're doing surgery. Okay. We're going to want to know, when did she last eat? We want 6 to 8 hours. Again, because of aspiration. So unless it's urgent emergent, unless she comes in, unless she, you know, let's say she has a cord prolapse, it does not matter now what time she ate, right? Because that's an emergency. But if it's not an emergency, I don't want 6 to 8 hours. I don't want her to have anything for the last 6 to 8 hours except, well, really, she should be NPO completely, not just food. There is some, like the hospital that I came from was having them do a high carb drink. So they were doing Gatorade 2 hours before. And that's a whole different protocol. But for you guys, for your purposes, nothing. Okay. So these are just some of the things we're thinking about. We're going to provide education about, she's having surgery. So about deep breathing after. We're going to do compression devices on her legs to minimize the risk of blood clots, stuff like that. She's going to get a Foley catheter because we're going to be cutting right by where the bladder lives. And so we need the bladder to be empty. Okay. And then our post-op assessment is going to be all of our normal postpartum assessment plus surgical assessment. So now I'm looking at her incision site. I'm looking at her dressing. I am considering how well she's moving air into the bases of her lungs. I'm still considering blood clots, things like that. So now moving on to our postpartum patient. Okay. The bubble HE acronym reminds us of the things we're assessing above and beyond our normal head to toe. All right, and we're going to break it down further here. So for health promotion, Health promotion, we talked already about how she's not going to get the RhoGAM vaccine in pregnancy. So now that she's not pregnant anymore is a great time for her to get the rubella vaccine. She might also need RhoGAM. Why do we give RhoGAM again? Why would I give the patient RhoGAM?
To suppress the immune, to suppress the immune system response.
RhoGAM is for RH negative mom with RH positive baby. And it does suppress the immune response because what it's going to do is it's going to keep the mom's body from building up antibodies towards the positivity of the baby's blood. All right, but let's think about this for a second. There's a couple of things to consider for this, okay? The big takeaways, let's go back to rubella for a minute. Rubella is a live virus. You guys told me that. And so we need her to not get pregnant for 28 days after getting this because her body needs to build up antibodies. Okay, now, if I give her, let's say your mom is rubella non-immune and Rh negative. If I give her rubella and RhoGAM together, this one, rubella, wants an immune response. RhoGAM suppresses an immune response. Do you see the problem here? So if given together, they can be given together, but if given together, we need to recheck the rubella. They need to have a titer drawn to make sure that her body, to make sure her body builds up that immune response because the RhoGAM is going to suppress the immune response. And then the RhoGAM needs to be given within 72 hours in order for it to do what it's supposed to do to keep mom's body from developing antibodies towards the positivity from the baby. So 72 hours. Okay. All right, for the breasts, how are we treating engorgement? With engorgement, if she's planning to breastfeed, we can empty the breasts. She can hand express, she can feed the baby, she can pump, she can use cold compresses to help with the inflammation. She can use Tylenol and ibuprofen for discomfort. If she's not going to breastfeed, though, we don't want her to stimulate the breast. So she can do the cold compresses and the Tylenol ibuprofen, but we don't want to stimulate that milk to let down because remember, guys, every time the milk lets down, the breast refill. Okay. For mastitis, we want her to use warmth. We want to encourage the breast to empty. She can also do Tylenol ibuprofen. She's going to need antibiotics because that's an infection. She needs to be empty in her breasts. All right, what's involution?
The uterus is not able to contract correctly.
Well, you're thinking of subinvolution. Involution is when it's doing what it's supposed to. What's it supposed to do?
Contract
Mm-hmm.
down and become firm.
Yeah, so I had a student from one of my classes that sent me a message and asked what the difference is between uterine atony and subinvolution. So let's talk about this for a second. Involution, what I just asked you, what is it? It is the uterus returning back to its pre-pregnant state. So it does contract, and it contracts down until it goes back down into the pelvis where it was before. And it should go down by about 1 centimeter a day. Okay, so after delivery, it's usually right at the belly button, and then it goes down about 1 centimeter a day. It is contracting in order to do that. Okay, now subinvolution is the inability of the uterus to return to its pre-pregnant state. So why? Usually subinvolution is caused by something inside the uterus. So endometritis, which is that infection of the endometrium, or retained placental fragments. Now, this is different than atony. And here's why. Because with atony, let's look at the word atony. A means absence. Okay. And then the rest of it, atony, is tone. It doesn't have tone. It is not contracting. Okay. Now, if you have the absence of tone and you just had this placenta that has these huge vessels coming into it, feeding it, and now that placenta is gone, all these huge vessels are just open like this, unless the uterus tamponades those vessels and squeezes them. If the uterus does not squeeze those vessels, we can have a huge amount of bleeding. Now, this is a big issue in the first 24 hours. Biggest issue in the first 24 hours after delivery. Okay. If you have something in the uterus that is keeping it from returning to its pre-pregnant state, it is contracting some, but not adequately, because that it has, and that's subinvolution. And it can affect for weeks. Okay, subinvolution can affect, this is Anne, it's just like can affect for weeks after delivery. And so endometritis and retained placental fragments. That's our subinvolution. So that's the difference. Does that make sense? Okay, so with atony, a lot of what we talk about, so they need to be a separate thing, because atony is usually going to be our first 24 hours. We have massive amounts of bleeding. This is where our uterus is boggy. This is where the fundal height might be above the umbilicus and deviated, that the bladder's full, things that affect the uterus's ability to clamp down. With subinvolution, we have some contracting. We're not hosing blood. They still can hemorrhage with subinvolution, but it's not pouring out like it can be with atony. Okay. Atony happens in the first 24 hours. Subinvolution happens potentially weeks after. Okay. So we want the uterus to be firm. So we're going to teach them about the importance of fundal massage. Okay. Boggy is bad. All right. For fundal height and position, and I said the bladder affects this. So what are we thinking about? If the bladder's full, it's pushing up on the uterus, and it is affecting the uterus's ability to contract in that lower uterine segment. So that's where we might find the uterus deviated from the midline and above the umbilicus. And so what we need to do for that is manage the bladder. That's our action. Either depending on if they're bleeding currently, we can have them void, we can straight cath, we can place a Foley, we need to empty the bladder. Okay. So we just talked about bladder distension and atony. The other thing that we need to consider for bleeding are going to be our lacerations and hematomas. And so remember in transition phase of labor, we said we don't want a cervical laceration because they bleed like crazy. So we're helping control that in part of labor and avoid the cervical laceration. But that can cause, that can be a cause of hemorrhage postpartum. What might I see with a laceration that would be different? What might I see? If I assessed this on my patient, what might make me think, oh, I think she has a laceration?
Is it the trickling of blood?
Yep, it's that constant trickling. All right, so we did this. We did uterine atony, boggy uterus, fundal massage, massage the fundus. What medicines would I use to help the uterus contract?
Pitocin.
Pitocin. What else?
Methergin,
Okay, methergin. When would I not give methergin?
high blood pressure,
High blood pressure. Good. What else?
Hemabate,
Hemabate. When would I not give hemabate?
With
if
the
the patient has
asthma.
asthma.
With asthma. Good. And then the other one is Cytotec or misoprostol.
Misoprostol.
Yep. So those are the ones we'll use to help the uterus contract if we have uterine atony. So if I have a patient, she's bleeding, we massage the fundus, we manage the bladder, we give medications. So the big things, the way that I remember this is FFP, fundus, Foley, Pitocin. Okay. Now that's not
Miss
just
McBride,
a Foley. Yep.
I'm sorry, I'm a little bit confused on this because I feel like I had a question. So when are we doing the IV fluid bolus? Do you want to do that too?
Yeah.
Whenever the patient has a tachypnea.
So guys, here's the thing is that when I tell you fundus, Foley, Pitocin, that's not the end of it. That just because the thing that those are our initial steps. Our initial steps are going to be massage the fundus, manage the bladder, and give uterotonics. But I am concerned about hypovolemic shock. And so we also want 2 IVs. We also want fluids. We want to maybe have blood products on hold. We want to be ready for a huge amount. And truly, I mean, in my, I think exam 3 review, we talked through a scenario, and I can do that with you guys. Absolutely. I'm just looking at the clock and trying to be mindful of the time. But postpartum hemorrhage is a big part of what we're thinking about. And so if, so we're definitely considering a fluid bolus, and we want 2 large bore IVs, and we want to have blood products on hold. But our very first things are going to be fundus, Foley, Pitocin. Okay.
And all of that stuff is going to be on that like that hemorrhage crash cart that they push to the room, right?
Yep.
Okay.
Usually the meds aren't actually, they used to be, and it depends on the facility. Sometimes you have to grab it because like things like methergin usually has to be refrigerated. And I think hemabate does too. So usually you have to get it out of the fridge. But it's part of, the nurses know that this needs to happen. In fact, most of the time, if I'm going to delivery where I know there's a high incidence or high risk of bleeding, I bring the medicines with me. You know what I mean? So oftentimes they are in the room, but if they aren't in the room, then they are easy to grab. And then the other things, your Foley, your blood tubing, your extra IVs, your fluids, all that stuff's on your hemorrhage cart. Yep. Times that we're going to have increased risk for hemorrhage is going to be things like if she's been in labor for a long time, if her baby's big. So if that baby weighs more than 9 pounds, that uterus is tired, might not contract as well. If she had a precipitous labor also, increased risk of hemorrhage. If she's had a long labor and the uterus has been contracting for days, increased risk of hemorrhage, because remember, we need the uterus to contract and tamponade out those vessels. Okay. Now, in purple here, we have refusal for blood products. If my patient's a Jehovah's Witness and is going to refuse blood, I'd like to know before she's hemorrhaging. Okay. And then our signs, what's our signs of hypovolemic shock or hypovolemia?
Tachypnea, weak rapid pulse,
So tachycardia is usually number one. We can also see tachypnea.
Low
The other
BP.
one is going to be, yep, hypotension. Okay. And then DIC, guys, I didn't see it on your topics, but just know that this is when everything, the clotting factors aren't doing what they're supposed to do. So now we have widespread bleeding with DIC. Okay. The gestational trophoblastic disease was on the list. This, guys, is what happens when the egg that becomes fertilized is lacking genetic material. And so with this, what we see is the body thinks it's pregnant. She might start having some bleeding because there's no placenta. There's not actually an embryo. But the cells are proliferating at a really high rate. So the uterus is bigger than it should be based on the possible gestational weeks. Her HCG level is abnormally high. Oftentimes they have a really high blood pressure, and they can also have some nausea and vomiting. Okay, and with this, they have to kind of disrupt that cell proliferation. So it might need to be treated with surgery, but oftentimes they end up using medicines that are also used as cancer medicines, because that's the job, is to stop that rapid proliferation of cells. Our ectopic pregnancy is a valid pregnancy, but it's in a place it can't grow. Where do the ectopic pregnancies usually, where are they at?
In the fallopian tube?
Yeah, usually in a fallopian tube. And so with that, they'll give methotrexate, and methotrexate actually disrupts the folic acid, and it keeps the cells from being able to continue to divide. If we have a spontaneous abortion, we still need to assess to make sure the uterus is contracting and that her bleeding is normal. Placenta previa versus placental abruption. How can I tell the difference?
One is painless.
Good.
Placenta previa is painless, bright red bleeding.
Okay, and where's the placenta for this?
It is blocking the cervix.
Good. Yep, it's down low. It's low lying, and it's blocking the cervix. And she can't deliver vaginally now because the placenta is there.
Mm-hmm.
But that bleeding is painless. What's happening with an abruption?
Painful bleeding, dark red.
Good. So this is painful, rigid abdomen, dark red bleeding. What would we see with baby for this, with the abruption? Probably late decelerations.
Okay.
Because if the placenta is separating, then we have less blood going through the placenta to baby. So we can see late decelerations because it creates a placental insufficiency. All right, diabetes. Gestational diabetes is going to be when they develop diabetes after they've become pregnant. Okay, so we test women at around 26 weeks gestation. They do that glucose tolerance test, and we test for gestational diabetes. Gestational diabetes is usually able to be managed with diet, but not always. Sometimes they need insulin. For our pre-gestational diabetics, their insulin needs are going to change during their pregnancy, okay? Because that the body wants to hold on to that glucose to grow the baby. And so her insulin needs in the first trimester are going to stay the same or maybe even go down a little bit. But as the pregnancy progresses, the insulin needs go up and up and up, 2 to 4 times what she was taking before. All right. And then as soon as the baby's born, the body very quickly returns back to that pre-pregnant need. So her needs will go down. Okay.
Can you repeat the part about the insulin needs in the pregnancy, please?
Yep. Insulin needs increase 2 to 4 times in the second and third trimesters. It goes up. So let's say she was managing this is for your pre-gestational diabetic, okay? If her pre-gestational insulin need, let's say she was taking 20 units every day at night. Let's say that's what she was taking. As her pregnancy progresses, her body holds more glucose. It tries to keep it to grow the baby. And so now her needs start going up. So by the end of pregnancy, she might need 60 units for the same diet she was eating before, because her body's hanging on to all that glucose. So her insulin need goes up 2 to 4 times what she was using before. Okay. After the baby's born, by about 10 days postpartum, she'll be back down to 20 units. Her body will very quickly adjust back down.
Okay, Professor, thank you.
All right, preeclampsia. So guys, with preeclampsia, remember guys, with this, we have hypertension, and then we have another symptom. And our other symptoms are typically going to be one of these things here. We can see a lot of different things, but we're thinking about thrombocytopenia. We're thinking about proteinuria. We're thinking about elevated LFTs, our liver function test, because the liver's not working well. We're thinking about headaches that are none relieved by Tylenol, visual disturbances, things like that. Sudden weight gain. So I asked you guys earlier when we were talking about prenatal visit, and if she gained a lot of weight very quickly, what I might think about, and it's that abrupt onset edema that causes her to gain a lot of weight can be a sign. The headache is very common. Right? If you think she has signs of preeclampsia, put a blood pressure cuff on her. Okay, put blood pressure cuff on her and see what you get. We had a discussion this term where she was a poorly controlled diabetic, and she had this headache that was not going away, and all of a sudden she gained a lot of weight. The very first thing I had done with that girl is put a cuff on her and said, what's her blood pressure? All right, we're treating preeclampsia with magnesium sulfate. Guys, this is a calculation you should know how to do. All right, the calculation for magnesium sulfate and the calculation for Pitocin. They are both on the list. Okay. If she has severe preeclampsia, we will probably induce labor. If she is on magnesium sulfate, we need to watch for signs of toxicity. You guys remember signs and symptoms of toxicity with magnesium sulfate? What do you think?
Is it magnesium toxicity?
Yep.
So the decreased reflexes.
Yep. What else?
Oh, the output, I think.
Good. What's the output supposed to be?
It's supposed to be 30 mLs.
Okay, so less than
hour.
30 would be concerning. Decreased DTRs would be concerning. What else?
Decreased respirations.
Good. Guys, remember everything with this slows down. So if it's a CNS depressant. So if we slow down too much, those are the things I'm worried about. So anything that's low, absent DTRs, low respiratory rate, slurred speech, muscle weakness, low urine output is too much. Okay. The thing is too, is this affects the contractility of the uterus. And so it increases her risk of postpartum hemorrhage. So if I have a patient that delivers and is on magnesium sulfate, I'm concerned about the possibility of a hemorrhage for her. If she has a seizure, we need to stay with the patient. We need to protect her airway. All right, preterm labor. What are my signs and symptoms of preterm labor?
Pelvic pressure,
Yep,
back pain.
yep. A lot of times, guys, if I see a woman that comes in for preterm labor and is in preterm labor, she's not acting like she's having contractions. She says, oh, I just have so much pressure in my pelvis and I just have this dull ache in my back. I keep feeling like, I don't know if the baby's pushing into my, like, I don't know. And it turns out it's contractions that she's feeling. So if she's having preterm labor, we know that it's labor if we have cervical change, right?
Mm-hmm.
How am I treating? What am I going to do?
Give her tocolytics.
Okay, we can give her tocolytics. Let's try to slow it down. All right. Magnesium sulfate actually acts as a tocolytic. That's why if I go back here to the slide where it says that magnesium sulfate for my preeclamptic patient can cause increase the risk of postpartum hemorrhage, is because it impairs the uterus's ability to contract well. So we can give her magnesium sulfate in preterm labor, but it's not really going to keep her pregnant for long. We don't usually use it for that. We will use it for neuroprotection. Nifedipine is one we use. That's a big one we'll use for preterm labor. This, though, is a blood pressure medicine, so we need to check her vital signs. Okay, so let's give her tocolytic. Let's try to keep her pregnant for a little bit, and let's give her betamethasone. What's betamethasone going to do?
Help for lung maturity in the
You
baby.
don't sound very sure. You're right, but you don't sound very confident about it. And that's the kind of thing that makes you change your answer, and then you get it wrong. So you're right. It's going to help promote lung maturity. All right, chorioamnionitis. This is our infection that can happen usually during labor. All right. So what are our big signs and symptoms of chorioamnionitis, do you think?
Is that the foul smelling?
No,
Yep.
maternal
Yeah.
and fetal tachypnea, right? Fever.
Okay, fever, Sabina, fever, and what else did you say?
Mom and baby.
Tachycardia.
Yeah.
Tachycardia.
Yep. Mom and baby are both tachycardic.
And
And then the
when
foul
to
smelling
touch
fluid.
Oh, and
smelling fluid.
Tenderness. The
And the
uterine.
abdominal uterine tenderness. Good. All right, so we're treating with antibiotics for this. Now, the other thing is cord prolapse. When the water breaks, we talked about assessing color, odor, volume, time, and all that. The other thing I want to know is, where's the cord? If the water breaks and brings the cord out with it, and I can see a cord, what do you think?
Trans-Dillenberg.
Okay, let's let gravity help get the baby off the cord, so we can do knee, chest, or Trendelenburg. Can she deliver vaginally if we have a cord prolapse?
No, she cannot.
No, this is an emergency.
She could do a
We're gonna
emergency
get the
C-section.
baby off the cord and go to C-section.
Is that when you put your hand in there and try to lift the baby's head up, right?
Yep.
Okay.
So we can do Trendelenburger knee chest, and then with fingers, we're holding the baby off the cord. Yep, good. All right, precipitous labor. What's precipitous?
Labor, whatever is
Less
in a
than
very
3
rush,
hours?
like in less than 2 hours.
Okay, usually less than 3
3
is
hours,
our
okay.
criteria, but yes, it's super fast. And so with a super fast labor, now we have a baby that's probably got some late decelerations because the uterus is contracting so much that's decreasing blood flow through our placenta. We have a uterus that is going to be exhausted afterwards, increased risk of bleeding. Okay, and that baby comes out fast, so increased risk of trauma to her bottom, lacerations, hematomas. All right.
Right.
Induction of labor. How do I induce labor? Why would I induce labor? When would I not induce labor?
We would induce labor if she is, 42 weeks?
Okay, 42 weeks. That's the time.
Preeclampsia.
Okay, good.
Preeclampsia.
And baby, macroscomic baby.
Good. Yep. What about if our baby was
Any
growth
emergency?
restricted? What if the baby was little? Then maybe. For an emergency, probably if it's an emergency, we would do a C-section, right? When would be some times that I would not induce labor?
If the baby's lungs are not mature enough.
Okay.
If she is placenta previa.
Yep. So
Yeah,
here's
previous.
the biggest way to know I should not induce labor. If the baby should not deliver vaginally, I shouldn't induce labor. So placenta previa, herpes lesions, how about breech presentation? Okay, if she should be a C-section, we should not induce labor on her. Okay.
Okay.
Those are our big contraindications for labor induction. Is if she shouldn't deliver vaginally, we shouldn't induce labor on her. So then we learned about how to decide if we need to ripen a cervix or if we just need to give her contractions. Do you guys remember how we decided the cervical inducibility?
Maybe, I don't know, I'm just about to guess. Maybe if she's having contractions with no cervical change.
Okay.
Maybe.
Well, to determine whether or not her cervix is to determine her cervical inducibility, let's do a Bishop score. The Bishop score is where we feel the cervix and we can score it. It's based on criteria. How dilated is it? How effaced is it? Is it firm or not? And then whatever the Bishop score is, if the Bishop score is low, we should use a prostaglandin like Cytotec or prostaglandin gel to soften the cervix first. If the Bishop score is high, we can just give her contractions. What do we give her? What do we give her to make her contract?
Oxy or Pitocin.
Yeah, oxytocin or Pitocin. Okay. Now, guys, you need to know how to calculate oxytocin. That's the other one that can show up on here, right? So we can use oxytocin in small doses to induce labor. We can use oxytocin in high doses to help with postpartum hemorrhage after delivery. Okay. But because oxytocin has such a strong effect on the uterus's ability to contract, if I give her too much while she's pregnant, then it can cause adverse effects. It can decrease the perfusion to the baby because it can cause her to contract too much. That is why on this thing here, one of the considerations for late decelerations was turn the Pitocin off. Okay, because I can make her contract too much and affect the perfusion to the baby. All right. If the contractions are too strong, too close together, and I'm affecting the placental perfusion, I mean, she might even need a C-section if my baby's having big decelerations. So we have to dose it carefully. All right. Vacuums and forceps, I would look over it. Our emergencies, we talked about our cord prolapse. All right, you guys know what shoulder dystocia is? Do you remember shoulder dystocia? Shoulder dystocia is if the head delivers and the shoulder's stuck.
Yes.
Okay, that's our other big emergency. All right, and that's when we did McRoberts. Remember McRoberts for shoulder dystocia. Then some of our other things that were high risk, we talked about, talking about cytopenic purpura. We talked about von Willebrand's and different coagulopathies. For our venous thrombolytic disorders, there's a difference between VTEs and DVTs. VTEs are superficial. So you might be able to palpate a hardened vein in the calf, things like that, where our DVTs are deeper. And that's when we're going to see things like unequal calf size, warmth, redness, things like that. For postpartum infections, guys, if she has a fever greater than 100.4 and it's more than 2 days, and it's after the first 24 hours, then I'm worried about, does she have endometritis? Does she have mastitis? Does she have a wound infection? Why does she have a fever? Know the difference between postpartum depression, postpartum and baby blues, and psychosis. All right, a lot of the teaching is going to be revolving around postpartum depression. All right. So what are some ways that I can identify it's depression instead of psychosis or blues?
She doesn't want like any involvement with the baby.
Okay. So there's detachment.
And she's crying.
She might be crying with blues though.
Okay.
Mm-hmm.
She has like mood swings.
Yep, and she might have mood swings with blues too. So guys, blues tends to subside by like 10 days postpartum. If the symptoms are worsening, that's a sign that it's depression. If they, detachment, you guys said, a lot of these symptoms are still going to be, some of them are similar to blues as far as mood swings and crying and things like that. But if the symptoms are getting worse instead of better, that's concerning. If she's not taking care of herself, if she's not taking care of her baby, she doesn't want to get out of bed, she doesn't want to eat, she's not resting well, all of these can be signs of depression. So we need to really provide good education about when to contact the healthcare provider. And if the symptoms are worsening, I'm not waiting to the 2-week mark to decide if it's blues versus depression. If the symptoms are getting worse, she should contact her healthcare provider sooner. And I often educate the dads on that because the dads will notice it sometimes even before she notices it.
I have a quick question about that.
Yep.
So just remembering from the last exam, and this one I wasn't sure, but I remember it. It was asking about a patient with postpartum psychosis, and it was saying something like, which one would be, saying that she has postpartum psychosis. So it was like, her saying that she is having thoughts of harming herself. And then it was, which I had did that for a postpartum depression. And then it was like hearing voices or something like that. So I had picked the one with her hearing voices. Was that the right one for psychosis?
Okay. So depression they might have thoughts of self-harm. The difference is they're not going to act on it. They lack the impulsivity. So with psychosis, they have the impulsivity to do it. Okay. So with depression, they might think about it, but they're not acting on it. With the psychosis, we get the auditory hallucinations, we get the bizarre behaviors, we get that impulsivity.
Okay.
Okay, so it is normal to have thoughts of self-harm with depression, but they're not doing it. It's the psycho, I don't remember how the question's worded exactly, but it's where you get that impulsivity to act on suicide that is the problem with psychosis.
Okay. Okay, so I got that one right. Okay.
Okay, good. All right, newborn stuff. So guys, we've talked about respiratory distress. We talked about thermal regulation, because remember that lady that delivered on the plane, we put that baby skin to skin. All right. Remember, guys, that if our baby gets cold, that can lead to hypoglycemia, because that when the baby gets cold, then they don't shiver. So they start burning their own brown fat, and it causes this whole cascade, and it can lead to hypoglycemia. So if my baby's cold, I want to check the blood sugar. Okay. What's our normal newborn stool?
Meconium.
Meconium, black and tarry. And then what does it transition to?
For if they're breastfeeding, it'll turn to yellow CD.
Breastfeeding, that it's a yellow CD.
Yep, yellow CD. All right, so hypoglycemia and hyperbilirubinemia are the most common issues we see with newborns besides respiratory distress. Okay, we're giving babies vitamin K, and we're giving them erythromycin eye ointment. The vitamin K is going to help, that we give them is going to help because that their livers aren't making the clotting factors well yet. So vitamin K promotes that formation. All right. For jaundice, what's jaundice?
Yellowing of the skin and the sclera on the babies.
Okay, good. And what causes that?
Whenever
the bilirubin,
the breakdown of the red blood cells.
Perfect.
Hyperbilirubin, that's what it is. Hyperbilirubin.
Yep. Hyperbilirubinemia, which is caused by breakdown of red blood cells. So in our babies that have cephalehematomas, they're going to break down that red blood cells, and they're going to have hyperbilirubinemia. So there's physiologic and non-physiologic. Okay, so physiologic jaundice is going to be things like breaking down a cephalhematoma. It happens after those first 24 hours of life. If we see a non-physiologic jaundice, this is going to be your like Rh incompatibility. All right. If mom was Rh negative and her baby was Rh positive on her last pregnancy and she didn't get RhoGAM and this baby's positive too, then we have erythroblastosis fatalis. So those red blood cells are getting broken down before that baby's even born. And so those babies are jaundiced faster because we are hyperbilirubinemia faster. Okay, so that's physiologic and non-physiologic jaundice. How do we treat jaundice?
we have to feed them, suggest a mother to feed every 2 to 3 hours. And then we put them under phototherapy, but we have to cover the eyes.
There you go. Feed the baby because it's going to be excreted through the feces. Get the baby eating, and we're going to do phototherapy. Good job. All right, for newborn immunity, they're going to get a lot of immune factors through the breast milk. All right, their immune systems are a little immature at first, but breast milk is going to be a great way to give those immunologic factors, especially in the colostrum. Acrocyanosis, normal or abnormal?
For first 24 hours, it's normal.
Normal.
And what does it look like?
It's
blue extremities.
Blue extremities.
Bluish extremities, hands and feet. Good. What's caput?
Caput. Oh, is that when the baby's head
is?
Yep.
Is it normal or abnormal?
It's normal.
Normal.
It'll go away, right?
Yep, good. Caput is just a superficial edema on the presenting part of the head. and it crosses the suture line because it's superficial and it's normal and it goes away. Cephalohematoma is a deeper problem because now it's a collection of blood and it's not going to cross the suture line because it's deeper. And then our complication for this is our hyperbilirubinemia and jaundice because the red blood cells have to be broken down. Okay. So APGAR score. You guys remember how to do APGAR score?
Yes.
Perfect. What is SGA?
Small gestational age.
And what criteria, how do I know if my baby's SGA?
Below 90% centile.
Not quite.
Well, no. Okay.
You're below
10%.
what? There you go. SGA is small for gestational age, below 10th percentile. LGA is large for gestational age, above 90th percentile. Okay. So when the baby comes out, we're going to dry and stimulate the baby. If we suction the mouth first. All right. If the baby is not breathing, how long can a baby have a respiratory pause and it be okay?
27
20.
seconds.
Okay,
Ish.
up to 20 seconds.
The 20.
If the baby is not breathing, I might need to give positive pressure ventilation. Most of the things with a low APGAR score can be fixed with breathing. Okay. So our vital signs, our temps, our respiratory rate. What's our normal respiratory rate for a baby?
30 to 60.
30 to 60.
30 to 60. We're going to do eyes and thighs. So we're doing vitamin K and eye ointment. You guys already told me that this is, the eye ointment is for most commonly caused by the erythroblast. I'm sorry, not oh my gosh, the ophthalmic ointment for neonatal conjunctivitis is caused by gonorrhea and chlamydia.
Professor McBride, I have a question really quickly. When we ventilate, are we giving the babies that surfactant?
No,
No?
if we're
Okay.
doing positive pressure ventilation, we're just doing breaths
With the bag, right?
with a bag. If
Okay.
we need to give surfactant, that's a separate thing, and they have to put an endotracheal tube in to put surfactant into the baby's lungs. That's not something that's not something we do. That's above our pay grade. Okay.
Does
Usually
respiratory handles that?
respiratory along with the neonatal nurse practitioner.
Okay.
Okay. And then we're doing our measurements. So I want to talk about this though, asymmetric SGA and the head and chest circumference. So what this is so Tia just told us that small for gestational age is below the 10th percentile. Okay. Now, typically when you do your measurements on your baby, the head and chest circumference are similar. Okay. If you have an asymmetric SGA, you have a head and chest that are not close to the same. All right, the head is larger, the chest is smaller. And typically our risks are still with our asymmetric SGA comes up if we have things like severe preeclampsia and things like that that cause this kind of chronic decreased perfusion to our babies, and they just kind of don't grow, they grow asymmetrically. But a lot of our concerns are still going to be hyperbilirubinemia and hypoglycemia. Okay, even with our asymmetric SGA. So if you have a head circumference and a chest circumference that are vastly different, we have asymmetric SGA, and our priorities for that baby is going to be probably related to hypoglycemia first, hyperbilirubinemia second. Okay. You guys know if you're going to do a blood sample on a baby and you're doing a heel stick, you need to stick the outside edges of the foot, not the middle. Teaching and considerations with circumcision. What do you guys think?
To clean the area only with water, not soap, and to make sure that the, oh wait, no, that's the navel. I'm thinking about folding the diaper down. And no creams or lotions or anything on the circumcision.
Okay. Okay, we're gonna keep it clean. We need to give good education to parents. There's a consent that has to be signed before circumcision. Babies usually will get Tylenol at the time of their circumcision. During the actual circumcision, they're kind of on a board. So we need to have a bulb syringe in case they kind of have secretions or if they spit up while they're laying like that, because you don't want them to aspirate. We need to keep them warm. So they often do it with either a heating light or on a radiant warmer. And then keeping it clean and cleaning it with water. I'm trying to think what else. Depending on how they do it, if they do it, there's like one that's a Plastabel that just sits on there and you leave it alone and it falls off when it's ready. If they don't do that and they just trim the foreskin, then oftentimes then there's like a Vaseline gauze you'll put over it so it doesn't stick to the diaper. Okay. Attachment. So attachment is what we are assessing as nurses after a baby's born. We're looking at, you know, those behaviors like singing to the baby, talking to the baby, participating in care, things like that. And then discharge teaching. What kind of things might we want to teach?
Just in general for a newborn?
Yeah.
Oh, they should be having, what is it, 6 to 8 wet diapers a day?
Good. 6 to 8 wet diapers a day. What else?
You can either feed on demand
Feed on demand.
or for breastfeeding babies, is it 2 to 3 hours?
It's 2 to 3 hours. We do want them to feed on demand also. However, if it's been more than 3 hours, they should be trying to latch the baby. Yep. Good. Okay, car seat safety, put him on the back to sleep, how to take care of the umbilical cord, when they need to follow up with the pediatrician, things like that. For our high-risk newborn, the things that we'll focus on has to do with the possibility of skeletal injuries. What's the most prevalent time to have a clavicle fracture? Do you think?
Macrosomic baby?
Macrosomic babies and shoulder dystocias. Good. For sepsis, for neonatal sepsis, so the biggest way we can prevent sepsis is good hand washing, right? But babies that are born to moms that had chorioamnionitis have a higher prevalence of sepsis. Babies that are preterm have a higher prevalence of sepsis. A lot of times with sepsis, we are seeing hypoglycemia. We can also see temperature instability, but not hot. Not like a fever, they tend to be cold. Okay. And tachypnea, which is why it can be confused with respiratory distress. If our babies are born to diabetic moms, then we're thinking about our macrosomic babies. We're thinking about birth injuries. We're thinking about the baby becoming hypoglycemic, right? Because that their body has been creating all of this insulin to combat all the glucose it's getting from mom. And now we cut off that insulin supply, but their body's still making this much insulin. So hypoglycemia. Okay. Babies that are born to diabetic moms also have a higher prevalence of respiratory distress because they don't make as much surfactant. Okay. Our big things with our pretermers has to do with respiratory. And so our respiratory distress signs and symptoms are the same. We're still thinking about thermal regulation and all that for these babies. Newborn nutrition. So Jasmine already talked about feeding on demand and things like that. We can teach breastfeeding cues, how to know your baby's hungry before they're frantic. How do I know if the baby's getting enough? Yeah, yeah. Rooting, chewing on their hands, mouthing things. How do I know if the baby's getting enough to eat?
If they making enough wet diapers, right?
Right, so 6 to 8 wet diapers a day, what else?
Weight gain.
Okay, weight gain is another one. We could look,
They don't want or after you feed them, if they full, they full. Yeah, they should be.
Okay. Maternal antibiotics can cause thrush in the newborn. So what's thrush?
Oh, the white yeast on their tongue.
Yep, good. So that's the thing, right? Is that antibiotics can cause yeast, right? And so women can get yeast infections with antibiotics. And same true that the antibiotics can cross from the breast milk to the baby, and then they can develop that in their mouth, which that's what thrush is. So they might need, if they see those white patches in there, they might need to be treated for that. How to manage dietary preferences with breastfeeding. I think we talked about this in relation to like certain foods, and caloric intake for breastfeeding should be around 500 calories per day. The other thing I think is they should still be taking their prenatal vitamins. How do you improve an insufficient milk supply?
Maybe massage the breast stimulation.
Okay, let's get the breast emptying. Remind supply and demand. So they can, after they feed, they can pump.
Yeah.
Okay. There are some medications they can use too, but for the most part, we just want to increase the emptying of the breast. So for fetal loss, this was our week 9 stuff. Okay, so in my slides, I had several slides on how to manage fetal loss. And so what we're thinking about for this, we need to think about mom's health condition. So we need to make sure her fundus is firm, her bleeding is normal, stuff like that. But then we also have this whole other aspect because we have to facilitate the grieving process. Okay, and so we're creating mementos, we're taking pictures, hand molds, foot molds, things like that. And encouraging interaction with the parents, encouraging them to hold the baby, see the baby, having the baby available to them. These are all medications that could show up on your exam. These are all medications that we use in OB. Same with this slide. Here is your ROGAM info. Here is your rubella info. Rubella was on our key topics list on this last key topics list. And so we've talked about rubella a lot today. Here's a way to calculate Pitocin, a way to calculate magnesium. Here are 4 HESI Kahoot games. So for Tia, here you go, girl.
Thank you.
Tia likes to play the Kahoots. I don't think I sent out Kahoot games for this week, but I'll look at it and see if I can play with you guys. But these are the ones that I would play. Okay. I'm happy to look over these math calculations with you guys if you want to. But I know that we're way over on time, so it's up to you.
I would say yes, because I think I got my math questions wrong. I struggle with math and still have not have a tutor as of yet, and this is the end of the semester.
Okay, well then I'm going to stop our recording because I'm gonna get my board.